The previous video just ended very abruptly. So I was saying that suppose this is a picture of the pons, and just next to the pons we have the internal auditory canal. So in the from the pons, this is the cranial nerve 6 that is emerging from the cranial nerve nucleus. Also, there is a seventh nerve nucleus which I should draw with another color. Let's suppose there is a seventh nerve nucleus. Now the seventh nerve nucleus is present somewhat over here, but the nerve emerges like this. It revolves all the way around the cranial nerve 6 and then comes out, right? When, and the same is true for the opposite side as well. If I am talking about the central lesions to the pons, the cranial nerve 6 and 7 will be damaged together. But if there is some peripheral lesion to the cranial nerve 7, like suppose in the internal auditory canal, like over here, suppose this is cranial nerve 7 and also cranial nerve 8, which are moving into the internal auditory canal, and there is some schwannoma that is present in the cerebellopontine angle over here, or maybe extending into the internal auditory meatus or internal auditory canal. In those scenarios, we will have a damage that will affect both of these nerves together. The next thing is, yes, so in the internal auditory meatus, we have the cranial nerve 7 and 8 which are moving together. The next point is about the, the next point is about the jugular foramen. So jugular foramen contains cranial nerve 9, 10, 11 along with the jugular vein. The hypoglossal canal contains hypoglossal nerve, that is cranial nerve 12, and the foramen magnum that contains the brain stems, the spinal root of cranial nerve 11 and the vertebral arteries. So here you can see the Uworld table. The anterior cranial fossa has cribriform plate, and the cribriform plate contains the cranial nerve 1 olfactory bundles. Optic canal contains cranial nerve 2 ophthalmic artery and the central retinal vein. Superior orbital fissure contains cranial nerve 3, 4, 5, 1, 6 ophthalmic vein and sympathetic fibers. The foramen rotundum contains cranial nerve V2, that is maxillary. Foramen ovale has mandibular. Foramen spinosum has the middle meningeal artery and vein. The posterior fossa has internal acoustic meatus that houses cranial nerve 7 and 8. The jugular foramen that contains cranial nerve 9, 10 and 11 jugular veins. Hypoglossal canal contains cranial nerve 12. The foramen magnum contains spinal roots of cranial nerve 11, the brainstem and the vertebral arteries. The next point is about the jugular foramen syndrome, that is also called as the Wernicke syndrome. The lesions due to the tumor, trauma or infection. It is characterized by the cranial nerve 9, 10 and 11 dysfunction. Symptoms are related to the nerve affected. Loss of taste from the posterior 1/3 of the tongue, that is carried by the glossopharyngeal nerve, and you must remember that the taste and general sensations, somatosensations are also taken by the cranial nerve 9 from the posterior 1/3 of the tongue. The loss of gag reflex, which is due to the damage of the cranial nerve 9 and 10. Dysphagia, cranial nerve 9, 10 deficit. Dysphonia and hoarseness because of cranial nerve 10 deficit, because you know that the larynx is supplied by the vagus nerve through the recurrent laryngeal nerve and the superior laryngeal nerve and stuff like that. Soft palate drop and deviation of uvula towards the normal side. Okay, so just write it uvula away from the side of lesion. That makes things easy for me, because in Urdu we say that जुबान साथ देती है, uvula साथ नहीं देता. This means that the tongue supports you and the uvula does not support you, which means that the tongue will go towards the side of lesion while the uvula will move away from the side of lesion. The sternocleidomastoid and trapezius muscle paralysis because of the accessory cranial nerve deficits will also be seen. Now this is again a table about cranial nerve, specific cranial nerves and their what do they do and stuff like that. So olfactory cranial nerve is responsible for smell. Only cranial nerve without the thalamic relay to the cortex, and it is purely sensory, and we'll see the mnemonic later on. The optic cranial nerve is for the sight. It is not a peripheral nerve and it arises from the diencephalon. It is not a peripheral nerve and it arises from the diencephalon. We are talking about the optic nerve, and this is also purely sensory. The oculomotor nerve, it is a motor nerve. It is responsible for eye movements that are superior rectus, inferior rectus, middle rectus, inferior oblique. Now there is a chemical formula. It's not a chemical formula, but it looks like a chemical formula. So it is SO4 LR6 and AO3. I'm sorry. So it means the superior oblique is supplied by the cranial nerve 4, lateral rectus by cranial nerve 6, and all other extraocular muscles are supplied by the cranial nerve 3, that is the oculomotor nerve, and these other include superior rectus, inferior rectus, medial rectus and inferior oblique. Oculomotor nerve is also responsible for the pupillary constriction because it carries the parasympathetic fibers coming from the Edinger-Westphal nucleus, and these Edinger-Westphal, the parasympathetic fibers which are coming from the Edinger-Westphal nucleus are going to supply the sphincter pupillae and they act on the muscarinic receptors. The oculomotor nerve is also going to help in accommodation. Eyelid opening by levator palpebrae, because the sympathetic supply to the levator palpebrae is given by the oculomotor nerve. Then the palsy of the oculomotor nerve will lead to eye down and out with blown out pupil along with ptosis. This is the characteristic picture of the cranial nerve 3 deficit, and that will happen ipsilaterally, which means in the side of lesion. The next point is about the trochlear nerve, the eye movements by superior oblique muscle. It turns the eye down and in, internally rotate the eye. So reading and downstairs. So very characteristic scenario that they give you on the exam is that there is some person XYZ and he is unable to read the book, or he has difficulty coming down the stairs. So that is a way of telling that the person is having trochlear nerve deficit. Palsy symptoms: vertical diplopia when to look down in stairs and reading. Eyelids are tilted outwards. Head tilting away from the affected side to compensate. So that is also a purely motor nerve. Then we have the trigeminal nerve. Trigeminal nerve is a mixed nerve. It has motor as well as sensory component. So the motor component is going to the muscles of mastication, which are medial and lateral pterygoid muscles, the masseter and the temporalis. The facial sensations are ophthalmic, the maxillary and the mandibular divisions. Somatosensation from the anterior 2/3 of the tongue. Somatosensations means the sensation of touch, pain and temperature. Special sensation from the anterior 2/3 of the tongue, that is a sensation of taste, that are taken by the coda tympani branch of the facial nerve. The part of corneal reflex, that is V1, that is ophthalmic branch of the trigeminal nerve, is the afferent limb of the corneal reflex. Then we have abducens nerve. Abducens nerve is responsible for the eye movement. The lateral rectus, it is a motor nerve. The facial nerve, facial movements. Facial nerve is also a mixed nerve because it contains sensory as well as motor components. So the motor, it is, by the way, it is mostly motor. Sensory component is a small part of facial nerve. So facial movements, that is motor to face, eyelid closing and orbicularis oculi, taste from anterior 2/3 of the tongue, this is special sensation. Then lacrimation and salivation, that is submandibular and sublingual glands are innervated by the cranial nerve 7. Now you must remember that submandibular and sublingual glands are being innervated by cranial nerve 7. We'll talk about the glossopharyngeal nerve later on. I guess it was glossopharyngeal. Okay, but we'll see about the parotid gland innervation later on. But for right now, you must remember that the facial nerve is causing the submandibular and sublingual glands to increase their secretions. Then auditory volume modulation by acting on the stapedius muscle. And stapedius muscle, if this nerve to stapedius is damaged, or if the facial nerve as a whole is damaged, the person will develop hyperacusis, because normally the facial nerve decreases the intensity of sound that is coming to our ears by stimulating the stapedius muscle. The cranial nerve 8, that is the vestibulocochlear nerve, it is purely sensory. It is responsible for hearing and balance. The vestibular portion compensates for the compensatory eye movements. Lesions will result in vertigo, nystagmus and disequilibrium. The cochlear portion contains hearing, and lesions will result in tinnitus and hearing loss. The next nerve is the glossopharyngeal nerve. The glossopharyngeal nerve is also a mixed nerve. It exits the skull through the jugular foramen. The somatic motor stylopharyngeus muscle only elevates the larynx during the swallowing. The parasympathetic component, that is the parasympathetic component of the glossopharyngeal nerve is coming from the inferior salivatory nucleus, and then through the cranial nerve 9, that is the glossopharyngeal nerve, they go to the otic ganglion and then travel along the auriculotemporal nerve to the parotid gland. The take away point that you must never forget is that glossopharyngeal nerve, that the cranial nerve 9, is supplying the parotid gland. Facial nerve was supplying the submandibular and sublingual glands, while the glossopharyngeal nerve is supplying the parotid gland to cause the secretion of saliva into the oral cavity. Then general sensory sensations from the glossopharyngeal nerve, they take the sensation of the tympanic membrane, inner surface and eustachian tube, posterior third of the tongue, tonsillar region, upper pharynx, afferent portion of the gag reflex, the carotid body and the carotid sinus. The special sensations from the posterior third of the tongue are also taken by the this trigeminal nerve. The next thing is about the glossopharyngeal palsy. If there is damage to the glossopharyngeal nerve, there will be loss of gag reflex. Then there will be loss of taste from the posterior 1/3 of the tongue, loss of sensation from the upper pharynx and tonsils. There will be hemodynamic effects, tricks the body into thinking that they have low blood pressure. There will be high heart rate, vasoconstriction and increased blood pressure. Then there is vagus nerve, taste from the supraglottic region. vagus nerve is also a mixed cranial nerve, and if there is damage to the vagus nerve, there will be loss of taste sensation from the supraglottic region. There will be swallowing. I'm sorry. I'm talking about the vagus nerve. So vagus nerve is responsible for the taste from the supraglottic region. It is a mixed cranial nerve. From the supraglottic region, that is the most posterior part of the tongue, that is supraglottic region. It detects very small amount of taste, and if there is any taste sensation over there, that is detected by the by the vagus nerve, cranial nerve 10. It is also responsible for swallowing, soft palate elevation, midline uvula maintenance, talking, and cough reflex. The parasympathetic to the thoracoabdominal viscera and monitoring of the aortic arch and chemo and baroreceptors. So you must remember that they are monitoring the aortic arch receptors, while the glossopharyngeal nerve was for the carotid body and carotid sinus receptors. The next thing is about the accessory cranial nerve, and accessory cranial nerve helps you turn your head and shoulder shrugging. The turning of head is mediated by the sternocleidomastoid muscle, while the trapezius muscle helps in shoulder shrugging, and that is also motor in nature. The palsy of the accessory cranial nerve will lead to difficulty turning the head towards the normal side, and there will be a shoulder droop on the affected side as well. The hypoglossal nerve is responsible for movements of the tongue. If there is a palsy of the hypoglossal nerve, there will be protrusion of the tongue towards the affected side, and opposite side pushes the tongue away unopposed. The vagus nuclei. So the vagus nerve is a very large nerve, and that is coming from different nuclei, multiple nuclei. The first nucleus is the nucleus solitarius. Visceral sensory information, for example, taste, baroreceptors, and gut distension, is taken by the nucleus solitarius, and and the nerves that are coming out of the nucleus tractus solitarius are cranial nerve 7, 9, and 10. The nucleus ambiguous, that is motor innervation of the pharynx, larynx, upper esophagus, and swallowing of the palate, for example, for swelling and palate elevation. The cranial nerve 9, 10, and 11, only the cranial portion of cranial nerve 11, they are coming from the nucleus ambiguous. The dorsal motor nucleus, it is giving rise to cranial nerve 10 only, and that sends autonomic parasympathetic fibers to the heart, lung, and upper GIT. You may say that the dorsal motor nucleus of vagus is the main nucleus of the vagus nerve and main motor nucleus of the vagus nerve as well, but other nuclei also give their contribution to the vagus nerve. Now these are some reflexes, they are important, you must remember them. The corneal reflex, the afferent limb is by the V1 ophthalmic nasociliary branches, and bilateral cranial nerve 7 temporal branch and orbicularis oculi. So the sensations, if we use a wisp of the cotton and we touch the cornea, so the sensation of touch or pain, they are carried by the ophthalmic branch of the trigeminal nerve, and in response to that, the facial nerve will fire, and that will shut the eye by using the orbicularis oculi muscle, right? The lacrimation, it is the cranial nerve V1, loss of reflex does not preclude the emotional tears. Lacrimation means weeping. So when you are weeping, the cranial nerve 5-1 or the ophthalmic branch of the trigeminal nerve, that will take the sensation all the way back, and then again the facial nerve will bring the reflex lacrimation into action. But suppose there is some damage to the reflex arc, there is some damage to the ophthalmic branch of the cranial nerve, or maybe of the trigeminal nerve, or maybe there is some damage to the facial nerve. In any of these scenarios, the emotional tear that will be there, emotional tear is not dependent on the emotional tears are not dependent on the cranial nerves. So you must remember that even in the deficits of the reflex arc, the emotional tears will be there. The jaw jerk, which is not present in any normal subject, that is a sign of some problem or pathology. So V3, sensory muscle spindle fiber from the masseter. So V3, that is also a branch of the trigeminal nerve, but the mandibular branch of the trigeminal nerve that takes the sensations. And the V3, which is a motor nerve as well, that brings back, that causes the masseter muscle to contract and stuff like that. So the V3 takes the sensation and V3 brings back the sensation, which means that V3 is a mixed nerve that contains both sensory and motor components. The pupillary reflex, the light, the reflex in which when you shine the light in the pupil constricts. So the optic nerve, that is the nerve responsible for detection of the sight or detection of the light, that is the sensory or afferent component, while the efferent component, which causes the pupillary constriction, is mediated by the cranial nerve 3. Then we have the gag reflex. The afferent component is by the cranial nerve 9 and the efferent component is by the cranial nerve 10. Then cranial nerve speech test, it is not very important, but that is important when you are in your ward rotation and stuff like that. So for cranial nerve 10, the patient is asked to make the sounds k, 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 and when they make a sound like that, the palate will be raised, and we'll check if it is raising normally or not. For cranial nerve 7, the sound is me, because that moves the lips, and if the lips are moving symmetrically, which means that cranial nerve 7 is normal, and if they are moving asymmetrically, so we will see that there is some deficit to the cranial nerve 7. Then la, that is cranial nerve 12, that give us functionality of the tongue, that tests the functionality of the tongue. Then mastication muscle, three muscles close the jaw and only one muscle opens it. The three that are closing the jaw are masseter, temporalis and medial pterygoid muscles. The only one muscle that opens the mouth will be the lateral pterygoid. M's munch, lateral, M's will munch, M's will close the mouth. For munching we need to close the mouth, the masseter, the temporalis and the medial pterygoid, while the lateral pterygoid will lower it. When speaking of pterygoid with respect to jaw motion, it takes more muscle to keep your mouth shut, right? It is very difficult for some people like me. I am also among those people, because it is very difficult for me to keep my mouth shut. So there are three muscles which are helping to shut the mouth, like the temporalis, the masseter and the medial pterygoid, but it is for opening the mouth, it takes only one muscle, that is the lateral pterygoid. All are innervated by the trigeminal nerve, which is V3, or the mandibular nerve, right? Then we have temporomandibular disorder. There is constellation of symptoms with the temporomandibular disorder (TMD). Unilateral facial pains that worsen with the jaw movement. There will be headache and ear discomfort. The next thing is pathophysiology, temporomandibular joint derangement. There will be a pathological contraction of the muscles of mastication and hypersensitivity to the nerves that supply the jaw. The involved nerve in the temporomandibular disease is the mandibular nerve, that is cranial nerve V3. It is motor to the temporomandibular joint muscle, that is mastication, tensors tympani in the middle ear. Sensory component of the sensory deficits in the what is that about? The involved nerve with the temporomandibular joint is okay. So we know that the mandibular nerve has both motor and sensory components. The motor component to the temporomandibular joint muscles, which are muscles of mastication, to the tensor tympani muscle in the middle ear, while the sensory component of the mandibular nerve goes to the temporomandibular joint and mandibular teeth, as well as the floor of the mouth, inside of the cheeks, anterior tongue and much of the skin of the lower part of the face. As a result, patients with a temporomandibular disease involving the mandibular nerve can have both jaw pain and otologic symptoms, which are the symptoms of sensation of otologic symptoms, means symptoms associated with the hearing system or symptoms associated with the ears. The next thing is about the common cranial nerve lesions. The cranial nerve 5 motor lesion. If there is some damage to the motor component of the cranial nerve 5, jaw will deviate towards the side of region due to unopposed force from the opposite pterygoid muscle. The cranial nerve 10 lesion, uvula deviates away from the side of region, weak side collapses and uvula points away. The cranial nerve 11 lesions, it is vulnerable to injury in the posterior triangle of the neck. Suppose there is some dissection of the posterior triangle of the neck, which we are doing because of some lymph node dissection or something like that. If we are having an access to the posterior triangle of the neck, we can damage the cranial nerve 11. Weakness in turning the head to the contralateral side of the lesion, right? Because try turning your head on, suppose right side. If you are turning your head on the right side, you will feel that the left sternocleidomastoid muscle has become taut, right? And if you move your head to the left side, the right sternocleidomastoid muscle will be contracted, that will become taut. So it means that sternocleidomastoid muscle helps you move your head towards the opposite side, right? And if there is some lesion to the sternocleidomastoid, the head will not move to the opposite side, which means the head will be tilted towards the side of lesion. Shoulder droop on the side of lesion, and the left sternocleidomastoid muscle contract to help the head the left yes, that is something that I just told you, that the left sternocleidomastoid muscle contracts to help you turn the head towards right side. Then cranial nerve 12 lesion, it is a lower motor neuron lesion. Tongue deviates towards the side of lesion, that is brachial wounds, due to the weakened tongue muscles on the affected side. Then we have diabetic cranial nerve 3 mononeuropathy. So it is a very important concept that there are two types of lesion to the optic nerve, to the oculomotor nerve. First one is the diabetic ophthalmoplegia, and the second one is compression of ophthalmoplegia by a compression of aneurysm or stuff like that. We'll see that right now. So all the oculomotor nerves, cranial nerve 3, 4, 6 can be affected by diabetes, but unilateral cranial nerve 3 involvement is most common. It is caused by predominantly central ischemia, which affects the somatic nerve fibers but spares the peripheral parasympathetic fibers. So in this picture you can see that there is an arrangement of fibers in the oculomotor nerve, right? If I draw it over here, suppose this is a cranial nerve 3, this is the cranial nerve, the whole trunk of the cranial nerve. In this thing, the peripheral fibers are parasympathetic. The parasympathetic fibers are situated peripherally. Okay, let's start like this. So the parasympathetic fibers are located over here. These are the parasympathetic fibers which are located peripherally. The sympathetic fibers, just give me a second. The sympathetic fibers, they will be present in the middle, like this. I'm sorry, not sympathetic fibers. I'm really sorry. The parasympathetic fibers are located on the periphery, while the motor fibers, they are present in the middle, right? The motor fibers are present centrally. The parasympathetic laterally, not laterally. The parasympathetic fibers on the outside, while the motor fibers are present centrally. Now, if I tell you that there is something that we call ophthalmic artery that is moving in the middle, right? This is the nerve supply to the retina, not retina per se, but there is a nerve supply to this artery. Now, if I am talking about some external compression, like suppose there is some aneurysmal dilation and that is compressing the nerve from the outside, that will cause the damage to the parasympathetic fibers first and the motor fibers later, right? So the very first symptom of aneurysmal dilation or aneurysmal compression of the oculomotor nerve will be blown out pupil, which means the parasympathetic contraction of the pupil is not taking place and the pupils are widely open. That is a manifestation of compression. But if there is some ischemia because of diabetes, that will lead to diabetic neuropathy and that will affect these artery, and because of effect on this artery, the central fibers, which are the motor fibers, they will be affected first and the eyes will move down and out, because if there is oculomotor palsy, mostly the eyes will move down and out. So now let's move forward to the discussion. So they were saying that it is caused by the predominantly central ischemia, which affects the somatic fibers or the motor fibers but spares the peripheral parasympathetic fibers. Symptoms include ptosis, a down and out gaze, and normal light and accommodation reflexes. There is an NBME point that pupillary dysfunction is often an early manifestation of external nerve compression due to the injury to the peripherally located parasympathetic fibers, for example, the compression of the posterior communicating aneurysm. Now here you can see that aneurysmal dilation, aneurysmal compression of the oculomotor nerve, superficial parasympathetic efferents are present over here, and then you can see that if there is external compression, that will lead to dilated pupil and loss of accommodation, and ptosis and ophthalmoplegia will also be present. So here you can see that it is like that. So this is deep vasculature which is present inside the nerve, then there is an aneurysm and deep extraocular muscle efferents. This means that these are the somatic fibers or the motor fibers to the extraocular muscles. Deep diabetic ophthalmoplegia, it is sparing the superficial parasympathetic fibers because now the lesion is centrally located. So that will cause central infarction, and down and out position of the gaze will be there, normal sized active pupils, and ptosis will also be seen. The next thing is about the facial nerve lesions. So the facial nerve lesions are divided into upper motor neuron lesion and the lower motor neuron lesion. Before going anywhere, let's see this diagram. So you can see that this is facial nerve nucleus, right? In the facial nerve nucleus, the part of the cranial facial nerve that is below the facial nerve nucleus is called as the lower motor neuron part. The part of the nerve that is below the facial nerve nucleus is the lower motor neuron, including the nucleus itself. The nucleus, the nucleus and the nerve trunk that is below the nucleus is a lower motor neuron, and injury to this region will cause lower motor neuron manifestations. And the neurons which are coming from the cortex all the way to the nucleus, before the nucleus they are upper motor neurons, or lesion to them will lead to upper motor neuron deficits. Now if we look at the face, so here you can see that if the lower motor neurons are damaged, the lower motor neurons or these blue neurons, they are affecting the lower side of the face, right, only. And the the facial nerve nucleus is divided into two parts: the upper part, which supplies the upper part of the face, and the lower part that is supplying the lower part of the face. If there is some damage to the lower nucleus, or there is some damage to the lower motor neurons, that will lead to deficits on the ipsilateral lower part of the face only. But if there is some damage to the upper motor neurons, I think I am confusing myself. Let's read the text first. I'm kind of confused about it. Okay, so just remember that the side of regions are like this. Now let's move back to the discussion. So they are saying that if the location is upper motor neuron, so if the lesion is located in the motor cortex or connection from the motor cortex to the facial nerve nucleus in the pons, that kind of region is upper motor neuron. The affected side will be contralateral. The muscles involved with the lower facial muscle of expression, and forehead involved, forehead will be spared because of bilateral upper motor neuron innervation, and other symptoms will not be there. So yes, I was confusing myself. So if there is some lesion to the, suppose this neuron, if this neuron is damaged, so there will be loss of facial movements in the lower part of the face, right? But upper part of the face or the forehead will be spared because the upper division or the upper half of the cranial nerve 7 nucleus is supplied by both sides. Like suppose this is the right side, suppose that this is the left side and this is the right side. So the left upper motor neuron is upper motor nucleus is supplied by the left upper motor neuron as well as the right upper motor neuron, right? So if there is some lesion in the upper motor neuron on the left side, the upper motor neurons of the right side will be supplying the upper half of the facial nucleus, so the facial functionality on the forehead will be spared and only damage will be to the lower aspect of the face. The next thing is the lower motor neuron lesion, and the location for the lower motor neuron lesion is the facial nucleus anywhere along the cranial nerve 7. If the damage is to the nucleus or anywhere along the cranial nerve 7, the side affected will be ipsilateral. That is a very important differential. The muscles involved will be the upper and lower muscle of facial expression. The forehead will be affected, and other symptoms include incomplete closure of the eyes, dry eyes, corneal ulceration, hyperacusis, and loss of taste sensation. Now here you can see that if the nucleus is damaged, or the lower motor or the peripheral facial nerve is damaged, so the total motor supply to the face will be lost, and whole half side of the face will be lost. Like there will be loss of motor activity on the upper aspect, on the forehead and on the face, and the total facial expression will be lost. So you must remember it like that. The next point is about the upper motor neuron damage is caused by the middle cerebral artery stroke. Upper face will be intact because it is dual supply, and lower face will be affected. The lower motor neuron damage, there will be whole half of the face will be affected. Then there is a thing that we call Bell's palsy. The Bell's palsy, the very first thing that you must remember about the Bell's palsy is that it is idiopathic. The Bell's palsy is idiopathic, mononeuropathy of the cranial nerve 7. We don't know the cause of Bell's palsy, but if there is idiopathic mononeuropathy of the cranial nerve 7, that is called as the Bell's palsy. The most common cause of peripheral facial palsy usually develops after HSV reactivation. Other causes of peripheral facial palsy include the Lyme disease, herpes zoster, that is Ramsay-Hunt syndrome, sarcoidosis, tumors, for example the parotid glands, and diabetes mellitus. Now here you can see that in this particular woman, this side of the face is normal, like this is normal, and this side of the face is abnormal because she is trying to move the face is not moving, the eye is not closing, the face is not, she is trying to smile but the face is not smiling because the half of the face cannot move, and the nasolabial fold that should be present over here is being lost. The next point is about the treatment of the Bell's palsy. So we use corticosteroids with or without acyclovir. If we have HSV suspicion, we give acyclovir, otherwise we give corticosteroids only. Most patients gradually recover function, but aberrant rearrangement can occur. So why is it happening? Because of facial nerve damage, right? Suppose there is some tumor or there is some loss of the facial nerve. Now when the facial nerve is damaged, it is a peripheral nerve and it can regenerate by the process of Wallerian degeneration. But during the process of regeneration, you can see that the facial nerve has these beautiful fibers. There is a temporal branch, and the zygomatic branch, the buccal branch, the mandibular branch, and the cervical branch. The fibers from the mandibular branch, they can grow into the temporal branch as well, and the temporal branch is giving supply to the lacrimation muscle as well, right? So it may happen that whenever the person is trying to chew the food, he may start lacrimating. So those are called as the crocodile tears, and they are very characteristic in the aberrant regeneration of the facial nerve. So here you can see that whenever there is facial nerve palsy, there will be loss of forehead and eyebrow movements, inability to close the eyes and drooping of the eyelids, and there will be loss of the nasolabial and nasolabial folds and drooping of the lower lip. The spinal nerves will continue with the spinal nerves in the next session. Until then, Allah Hafiz, fi amanillah, and take care.